All right, so my job is in 10 minutes to 12 minutes to tell you everything you really ever wanted to know about diabetes. I'm guessing that there may be some things we don't get to, so you can ask me. Certainly at the end, we'll be around for questions. I think many of you may be already familiar with some of what I'm about to say at the beginning, but just to sort of level the playing field about how we diagnose diabetes and prediabetes. Many of you have heard these terms thrown around for a couple of years. So we actually use laboratory testing for these diagnoses. And we think about a fasting blood sugar. Your doctor might do fasting lab work on you if it's greater than 126 milligrams per deciliter. We still do sometimes send people for a glucose tolerance test where they make you drink that sort of orange soda drink. And if we check you 2 hours later, if your blood sugar is more than 200, that also is a diagnosis of diabetes. Or a random blood sugar, meaning when you're not fasting, you might have eaten at some time that's greater than 200 with symptoms, including I might be thirsty, I might be feeling a little tired, I might be peeing a lot. Those are symptoms of high blood sugars. And lastly, we use a hemoglobin A1C, which is a screening test. And if that's greater than or equal to 6.5, and if it's confirmed, we diagnose diabetes. So we require for any of these, if we do the test, that we have a second confirmatory test to actually confirm the diagnosis. And then prediabetes is actually basically the values that are just above normal but below the threshold for a diagnosis of diabetes. So a fasting blood sugar between 100 and 125, the 2-hour blood sugar of 140 to 199, or an A1C that's 5.7 to 6.4%. So some of you may know people or yourselves may have had a doctor tell you that you're in the category of prediabetes where the blood sugars are not quite meeting that threshold, but it's still really important to start focusing on risk factor reduction and prevention, both of diabetes and of heart disease. So what is hemoglobin A1C? This is sort of a nebulous concept to a lot of people. So we're actually measuring in this test your average blood sugar over 3 months. So we're not measuring the blood sugar when you show up at the office. We're not measuring the blood sugar when after you had dinner last night. It's actually an average, and it's the percent of sugar that has become attached to the red blood cells' hemoglobin molecules. And since your red blood cells last in your body for about 90 days, as long as you don't have an anemia or some other reason for that to be abnormal, the more sugar that lands on your red blood cells gets read out as a percent, and that's the hemoglobin A1C. So the higher the A1C, it just means in the last 90 days or so, the higher the blood sugars have been. So it's not one specific reading. You could be really good with your diet the week before you come to see one of us, and the A1C will still show what you were doing for the last 3 months. But before that, we can't really say. So I'm going to talk about a few questions that come up in the office and some that Nisha had mentioned, and Courtney runs a lot of our classes. People come in all the time and say, diabetes is caused by eating too much sugar. I did this to myself. I'm not eating well. I caused my diabetes. And a lot of people feel really badly about that also. And I think in society, we sometimes make people feel that they did this to themselves. So I think it's more appropriate to think about the fact that type 2 diabetes is caused by the inability of your pancreas to make enough insulin. Or there may be a problem with how the insulin is used. The body may make insulin, but it may not be working very efficiently. You may be resistant to its effects. So it's not because you ate too much sugar. But if you have diabetes, eating sugar will raise your blood sugar. So we do focus on that as part of your diet, but it's not causative. We do recommend eating a more balanced diet to help you manage your blood sugars and not to aggravate them. But if diabetes is not caused by eating too much sugar, then why do some people get diabetes and other people don't? And we will sometimes see very heavy people who have diabetes and very heavy people who do not have diabetes. And we see skinny people who have diabetes and skinny people who do not have diabetes. So I think we know that there are some risk factors and then some other genetic traits that are probably predisposing them. And people inherit genes from their parents that contribute to insulin resistance, and that's in your liver, in your muscle, in your fat. And that means that the insulin is trying to get the sugar out of your bloodstream. It's trying to get it into the muscle and the fat to be used as energy. It's trying to tell your liver not to make too much sugar because your liver is making sugar when you're not eating. When you're all sitting here listening, your body still requires sugar for energy. But those tissues are not really listening to the insulin signal. So the sugar is still floating around in the blood at inappropriate levels. And the cells that make insulin, which come from your pancreas, those are the beta cells, initially try to compensate by making more insulin. So early on in prediabetes and early on in diabetes, people make tons of insulin, but the message is not getting through. And if we don't address what's causing the insulin resistance, which might be lack of physical activity or being overweight, then the pancreas is working really hard, often for years. And over time, those beta cells get tired and they sort of burn out, and they can't keep up that higher level of insulin production. And that's when the blood sugars start to get abnormal. So people who are developing diabetes, maybe for 10 or 12 years before that, may have slightly abnormal insulin production and slightly abnormal blood sugars, and their beta cells are working really hard, maybe for a decade, actually, sometimes before they get diagnosed. So one of the reasons it's important to talk about this is now we can start looking for this earlier, and we can start doing some prevention strategies. So some risk factors that we know about are age, so diabetes is more likely as you get older, your ethnic background, African Americans, Latinos, Native Americans, Asian Americans, and Pacific Islanders have increased risk. If you have an immediate family member with diabetes, your mother, your father, your sister, or your brother, that is an increased risk. If you have a previous diagnosis of gestational diabetes, so if you're a woman who had diabetes during a pregnancy, the pregnancy puts an extra stress, a metabolic stress on the body. And in women who are predisposed, who have some of these genes, the blood sugars will be high during the pregnancy because their body couldn't keep up. If you are overweight or obese, that is a risk factor. But as I said, it in and of itself does not necessarily mean you'll get diabetes. If you are very physically inactive, so if you are sitting at your office all day like I am and you don't get up and walk around and go to the gym, that's a risk factor. And those who have prediabetes, so those people we already know about and we're usually following them, and they're at the highest risk over the next few years to develop frank diabetes. I also wanted to just mention that in society we have seen, this is from the CDC, that over the last 20 years or so, the risk and prevalence of obesity has increased and the prevalence of diabetes has increased at the same time. And a lot of people say that must be because our genes have changed. But our genes changed millions of years ago. So we inherited these and they were selected for millions and millions of years ago. Our environment has changed. And so now we have a lot of fast food, a lot of cheap food that's not particularly good for you that's high in calories. We don't have as many gym classes at school. We have a built urban environment. And we really have to look for ways to remain active. So the genes that people inherited, that now in this environment where there's plenty of calories, not so much activity, it's all coming out now in terms of an increased risk for diabetes and an increased prevalence for diabetes. But the next myth is if you are at risk for diabetes, there's absolutely nothing you can do to prevent it. And that is not true. So if you know you're at risk and you go and you ask your provider to actually test you to see if you are at risk, you can start making healthy lifestyle changes, including diet and exercise. And this can delay the onset of diabetes, even in those patients who already have prediabetes, which is the highest risk group. And this was an old study from many years ago, but this is the one that we quote all the time, that did intensive lifestyle in people with prediabetes and compared it to just general recommendations for good health and to metformin. And they followed people over 4 to 5 years. And they showed that intensive lifestyle with about a 5 to 10% weight loss could reduce the risk of progression of diabetes by 58%. Now, that's not forever. That doesn't mean these people never got diabetes, but they certainly delayed the onset of diabetes by 3 to 4 to 5 years. And in people who have diabetes, these same interventions improve their control. Maybe they need less medication. Maybe they have better cardiovascular health because they have improved their fitness. So these sort of are the foundations of the therapies that we'll talk about. One common question in the office is, if I have diabetes, does that mean I can never eat any carbohydrates ever again? And Courtney probably gets this a lot in the nutrition classes. This is not true. We do suggest a healthy, balanced diet. I will leave it to Courtney to talk about the specific composition of that diet, but we basically will say balance your diet with protein, with vegetables, with fruits, with fiber. Keep it low in salt to reduce the risk of hypertension, low in saturated fat. If you are going to eat carbohydrates, especially if you're eating them frequently with meals, look at your portion sizes, try to eat complex carbohydrates, not very processed foods, and save any processed foods for special occasions. A piece of birthday cake or a piece of wedding cake at a birthday or wedding is okay, but don't have pasta for dinner and then get up on the dance floor and dance it off. So you have to sort of be aware over the course of the day what you're eating and how much you're moving, and then we can account for these things. So the question that Nisha asked me was, I never know when to tell people, should they check a fasting blood sugar or should they check after eating? And your provider may ask you to do both of those. At the beginning, when you've been diagnosed with diabetes, we often ask you to start by checking a fasting blood sugar, just to get a sense of what your blood sugars are doing when you haven't eaten anything for 8 to 10 hours. Those, in theory, would be the lowest ones of the day. So normal would be less than 100. Acceptable for diabetes is less than 135. And we try to get you as close to 100 as we can. But if your doctor notices or your provider notices that your numbers still seem a little high, or your fasting blood sugars look great, but your hemoglobin A1C is a little high, then we suspect that you're missing some spikes that may be happening with meals. And then we may say to you, please check 2 hours after eating. A normal blood sugar would be less than 140. Acceptable with diabetes is up to 150 to 180. If you eat that piece of cake and your blood sugar is 210, you're close, but go take a walk, and perhaps the next time eat a little bit less. So although finger sticks may seem onerous, they do give you good feedback about what you've just done in the last couple of hours. And then the last myth I'm going to discuss here is it's inevitable you'll have to take insulin for your diabetes, and this means that you have not taken care of your diabetes properly. I think it's very important to remember that early in the course of diabetes, your body has a lot of reserves, and you may be well able to manage your diabetes with diet and exercise and lifestyle changes. But the pancreas does fatigue over time, and over 5 to 10 years, most people require medications, usually pills at first, and eventually they may require insulin, and that doesn't mean that they can't be healthy, and it doesn't mean they haven't managed their diabetes. I'm not going to go over all of these. These are all of the classes of medications. I'm going to simplify this by saying some of these make you more sensitive to insulin. That's things like metformin or the biguanides. Some help you make more insulin to overcome the deficits that you're having. Some help you get rid of some sugar in your urine. And others just directly stimulate the production of insulin. And finally, we sometimes just give you insulin to sort of make up the deficit. But the last thing I want to address is what people say when I'm about to prescribe something. So this is pretty random, right? The way you're going to pick what you want to give me, you're just going to pick whatever's most popular today. So if your diet and exercise are not enough, your provider generally will start with metformin. This is actually according to national guidelines, to sensitize you to your insulin, let your body work more efficiently. If you need a second drug, we have guidelines as of 6 weeks ago from the American Diabetes Association saying that the next drug really to add depends on whether or not you have cardiovascular disease. And so we now have some classes of drugs that can help in the prevention of cardiovascular disease and cardiovascular mortality. So we now actually have an indication from the FDA and from our diabetes associations to say, if someone has heart disease, please go ahead and add something like empagliflozin or liraglutide. You could consider canagliflozin. The first two have FDA approval for reduction in cardiovascular events. The second has evidence for it, but not yet FDA approval. And if you don't have heart disease, we actually just think about you. Are we worried about you gaining weight or losing weight? Are we worried about low blood sugars? Are we worried about pills versus injections? Are we worried about side effects? So it actually has to be individualized to the patient, but we have to move cardiovascular risk higher up in our list when we're thinking about what to add next to do effective prevention.
So I want to switch gears, but I do want to touch on something that Dr. Golden brought up, which is really important, which is the stigma that's associated with a lot of the conditions that we're talking about today. So I think diabetes being one of them, heart disease being another. A lot of times people that are diagnosed with these conditions just feel like other people are looking at them as, oh, I must have eaten badly, or I must have, done something wrong. I must have been a couch potato and not exercised enough, and that's why this is happening to me. And I think that that's something that society as a whole needs to address, that there's so many different factors that go into people's individualized risk, and that genetics plays a large role in a lot of it. So that brings us to our next topic, which is heart health and diabetes, and we'll sort of touch on more of these. So let's start with some scary facts so that I know that I have a captive audience. So heart disease is the #1 killer of both men and women in the United States, period. So that includes diabetics, that includes non-diabetics, that includes, just about everybody. More than any cancer combined, all of the cancers combined, heart disease is the #1 killer. It affects people with diabetes at a younger age. So this is particularly important when we talk about women, because back in the day, heart disease was thought to be a man's disease because it affects men first, right? So it affects men about 10 years earlier than it affects women, because women are protected until menopause. But all bets are off when you're a diabetic. So I can't tell you the number of times that we see diabetic women who are young, in their 40s and 50s, who come in with heart disease because, it sort of trumps the protective effects of hormones. The longer that someone lives with diabetes, the higher the chances that they'll develop heart disease. diabetics have a 2 to 4-fold increase in the risk of CAD or PAD. So CAD is coronary artery disease, which is what we're going to be talking about now. And peripheral artery diseases, primarily we're talking about the arteries in the legs, and that's what you're going to hear about from Dr. Parikh in just a few short moments. Diabetes is a coronary risk equivalent to known CAD. So this is something that we used to say a lot, and it's not entirely true anymore. What that phrase means, a coronary risk equivalent, is essentially that somebody who's a diabetic is as much at risk for a heart attack as somebody who's already had a heart attack, which is a really scary way to say that, but it's not entirely true anymore, right? So it's still true for about half of women, 2/3 of men. And the difference is probably that over the past 15, 20 years, preventative therapies, particularly statins, have become so much more widespread. And so, it's not as much of a risk factor, but still diabetes is a major cardiac risk factor. Diabetics are more likely to have multivessel coronary artery disease. So if they have heart disease, it's more likely to affect multiple different vessels. And if diabetics have a heart attack, they have a worse prognosis afterwards. So why is it that what's happening in the diabetic person that's making them more prone to heart disease? Let's go over a little bit of the pathophysiology of it. And what it is atherosclerosis. So that literally means hardening of the arteries. And I think this is a really important graphic because it gives us a lot of information. So if you look all the way on the left, that's the smooth inside of a normal blood vessel, right? And then over time with either poor diet or risk factors, you get the fatty streak, and then you get a little bit of plaque, and then the plaque increases. And it's something that's happening over time just because of a milieu of risk factors and, predisposition to atherosclerosis. And this could be age, this could be a number of different factors. But just having plaque is not actually clinically significant, right? So this is the plaque that you have that's not actually going to cause symptoms. You're not going to feel it. You're not going to know it necessarily unless you look. And the only way to look is by doing either a CT scan, which has radiation and contrast, or a catheterization, which has contrast and a procedure, right? So a lot of times this is assumed based on a person's risk. And the only way that we sort of treat this, or not the only way, but when we know that this exists, we're much more aggressive about preventative therapies like aspirin, like healthy lifestyle, like statins, right? These small plaques, right, the 20-30% plaques that we're talking about here don't show up on stress tests because, again, they're not clinically significant. It's just a precursor to heart disease to come, right? Then over time, if left unchecked, it can progress to obstructive plaque, and that's when it becomes significant. And we use, when we talk about the heart arteries, we use a 70% cutoff. So something that's more than about 70% usually that's where it starts to cause symptoms. So that's when somebody's exerting themselves, they feel some chest pressure, they stop, it goes away. That's when it's an obstructive plaque. That's when the stress test becomes abnormal. That's when it usually becomes clinically significant. And then when it causes a cardiac event, so a heart attack is what we're talking about, that it's when that plaque ruptures and causes a clot in the blood vessel, right? So this kind of gives you a very nice overview or a glimpse at the progression of atherosclerosis throughout, sort of a lifetime, and then the end result. And like I mentioned, atherosclerosis is actually a systemic disease. So it affects not just the arteries in the heart, but all of the arteries in the body. And so we kind of group these vascular complications into two buckets, right? Microvascular complications, which are basically the small arteries that supply the eyes and the kidneys. And those are actually affected by glycemic control. So if you can control your sugar and get it into, an almost normal range, you can limit the amount of microvascular complications. That's not so much the case for the macrovascular complications, the large arteries that we're talking about today. So heart disease, peripheral disease, carotid disease, it's something about plaque in diabetics that's just not the same as plaque in non-diabetics. So this chart actually gives me like PTSD from medical school, so don't look at it for too long. It's just meant to be just to give you an idea of how complex the interplay is amongst a number of different factors, which leads to abnormal, it's called endothelial dysfunction, right? So and the endothelium is the lining of all the blood vessels in your body. And so there's something that not only in diabetes, but in other, risk states, that you have endothelial dysfunction, which just makes your blood vessels more prone to inflammation and more prone to plaque formation. And then on top of that, diabetic plaque is also the more unstable plaque, more prone to rupture and leading to a cardiac event. And then, unfortunately, the other bad news is that cholesterol is also something, when you're a diabetic, your cholesterol is also affected. So the good cholesterol, the HDL, the protective effects are less. So the good cholesterol is not as good, and then the bad cholesterol is even worse in diabetes. And a picture is worth 1,000 words. So let's just compare. This is not meant to be subtle, right? So on the left, you see what normal coronary arteries look like. And it's just, again, just to get a visual, right? So large caliber vessels, nice and smooth on the inside. And then on the right, it's something that we call, sort of the diabetic blood vessels, right? So the lumpy, bumpy blockages in multiple different areas of the blood vessel, very small, tiny, tapered blood vessels. And so it just gives you an idea of the sort of widespread effects of diabetes. This is not meant to be scary. And so how does that manifest? So if somebody, when you do lead to that obstructive plaque, when it becomes clinically significant, how may that present? And certain subgroups, diabetes being one of them, but also women and also the elderly can present differently, right? So you're more, the sort of classic chest pain story, typical angina, is substernal chest pressure that's brought on by exertion or by stress and relieved with rest or nitroglycerin. That's the definition of typical angina. So, these subgroups are more likely to have either atypical angina or just not have chest pain at all and present either with, GI discomfort, nausea, vomiting, indigestion, abdominal pain, lightheadedness, general weakness. It's just something about not feeling quite right? And so we made this slide actually when we were talking about women, but this is very applicable today as well, right? So different matters. When there's just something about it, when you talk to people who have, heart attacks but didn't present with chest pain, it's just something about feeling different that brought them to the emergency room. And so different matters. If you're at risk, which being a diabetic puts you at risk, if you're at risk, you feel different, know your body, trust your instincts, and find a doctor who's going to take you seriously and look into it. So what can you do to prevent cardiovascular disease in diabetics, right? Because that's why we're here. We want to try to, preventing something is much easier than treating it after you have it, right? So what can we do? So the emphasis is very much on lifestyle habits, which is really important to note because medications are great and people can get very caught up in all the new, the new classes and the new outcomes and the new data. But really, it's about a healthy, sustainable lifestyle. It's not something, diabetes is a chronic illness. It's something that somebody's going to have to live with for the rest of their life. So it's not something you can do for a month or two and feel like, okay, check, I've done that. It's got to be something that's a sustainable diet, sustainable lifestyle for that person. So Courtney is going to be our expert talking about nutrition and diet. So I won't get too much on that, but I do want to talk about physical activity for a second, right? So what does that mean? How much physical activity are we talking about? 30 minutes of aerobic exercise, something that gets your heart rate up most days out of the week. So don't go more than 2 days without doing something aerobic. And if you can't do that during the week, which is really hard to do, especially if you're, working and you're in this conference room until 8 p.m., right? It's hard to do. There's the weekend warrior mentality, right? So 75 minutes of vigorous activity on the, 1 or 2 days a week, right? So on the weekend usually. And then I really love this quote, sitting is the new smoking. It was actually coined by the inventor of the treadmill desk. But anybody who is diabetics in particular, the guidelines say that you should not sit for more than 30 minutes at a time. So shame on us for making you all sit here for more than 30 minutes, but just doing anything to stretch your legs. And at the end of the day, any activity is better than no activity. So just do something, get up and move. And then I won't belabor the point about medications, but metformin is something that cardiologists are comfortable with. It's the first line therapy. It leads to weight loss, which helps with, blood pressure control and all of the other stuff that goes along with that, improves insulin resistance. And it's something that, historically cardiologists are comfortable starting metformin on their patients before you see the endocrinologist or the internist, right? The second line agents, just as Dr. Golden had mentioned, you want to consider the ones that have the recent proven cardiovascular benefits, and the oral version of that is Jardiance. I cannot say the generic names. I apologize, and that's the oral version. So I think that's something that as a society or as a community, the cardiology community is going to hopefully be more active in, feeling comfortable with. And then, so some of the other medications that we use for prevention of heart disease, right? So my rule of thumb is that if somebody is over the age of 50 and doesn't have some reason, that predisposes them to bleeding, that they shouldn't be on aspirin, then I prescribe a baby aspirin. So that's 81 milligrams of aspirin once a day for prevention. Obviously, if you have a history of bleeding or, ulcer disease or something like that, that's something you need to discuss with your doctor. And then blood pressure control, it's like all the buzz right now, right? So everybody's blood pressure goal is now less than 130/80, but vigorous blood pressure control in diabetics actually has more of a benefit in preventing heart events than in non-diabetics. And the classes that we favor are actually, or not just us, the nephrologists favor as well, the kidney doctors favor as well, is the ACE inhibitors and the angiotensin receptor blockers, the ones that end in pril or sartan. And that's because it prevents or it slows down the progression to kidney disease and diabetes. And it also has endpoints in cardiovascular disease as well. So those are sort of our go-to blood pressure medications in diabetics. And then just a point on statins. So I know this happened a few years ago now, so I'm sure everybody is sort of aware. But in 2013, they did a major overhaul of the cholesterol guidelines, right? And so it kind of goes back to that picture with the progression of atherosclerosis that I showed, right? It's kind of, you identify the risk and then there's a progression of it. So it's not so much what the number of your bad cholesterol, what the number of your good cholesterol is, although we do still look at that. But the new statin guidelines sort of focus on a person's risk for heart disease. And so the whole guideline has the flow chart for everybody is very complicated, but actually if you look at this table, it breaks it down for diabetes in particular. And so anybody with obviously known cardiovascular disease or anybody who's in the age, who's a diabetic and 40 to 75 should be on a high dose statin. And what is a high dose statin? That's usually Lipitor 80 milligrams or Crestor 40 milligrams, just because I know you were going to ask. And so that's sort of our general guideline on that. And then at the end of the day, it's really managing your overall risk for heart disease, right? We break down categories into, we sort of talk about the modifiable risk factors for heart disease make up about 90% of a person's risk, right? But I would argue that, being a diabetic, having high blood pressure, things like that, they're modifiable, but it's not something that a person can solely prevent, right? A lot of times the genetic risk sort of trumps any healthy lifestyle that you have. But again, these are things that you can modify that are within your control, either through diet, exercise, and medications, what have you. But let's focus on some of the other ones. So we talked about diabetes, we talked about high blood pressure, we talked about cholesterol. Smoking is the worst thing anybody could ever do for themselves, so just don't do it. Obesity and abdominal fat, again, just like with the diabetes, obesity is not in and of itself a cardiovascular risk factor. It's more like the company it keeps. So obese people are more likely to have diabetes, more likely to have high blood pressure, more likely to have high cholesterol. And it's really the abdominal fat that's the bad fat. So that's what you really want to watch. High stress, chronic high stress, that we did a whole seminar on this last year, right? But that's been shown in studies in humans to have a direct link to increased inflammation in the arterial walls and increased risk of heart disease. Poor sleep habits is actually something that young people are shocked to find out, right? But less than 6 hours of sleep in a night actually increases event rates, and people who live the longest sleep between 6 to 8 hours every night. And then depression has a strong link to heart disease and a number of other conditions as well. And then the non-modifiable things, the things that you can't necessarily control, age, race, family history, being a male, but again, that has an asterisk next to it because it's just being a male of a certain age. Women after a certain age are equally at risk. Preeclampsia or gestational diabetes, again, something that oftentimes women don't even realize is a cardiac risk factor. So a lot of times this happens in their 20s when they're having babies, and then let's say 30s now, 30s, 40s when they're having babies, and nobody even refers them to a cardiologist, right? And then what are the takeaway points that I want you to take from here? So diabetes is a major risk factor for heart disease due to the increased atherosclerosis, which we talked about. Plaque in diabetics behaves differently than plaque in non-diabetics. The key to preventing heart disease and diabetes is healthy lifestyle habits and aggressive control of other risk factors. And again, this has to be a sustainable sort of way of life that somebody's going to adopt, not a fad diet or anything like that. And the treatment of a diabetic patient, I really want to point this out, involves a team-based approach and regularly scheduled outpatient follow-up appointments. You don't know what you're at risk for because a lot of the cardiovascular risk factors you don't feel. So even being a diabetic, you may not feel it until it's very, sort of far along. High blood pressure, high cholesterol, these are things that you don't necessarily have symptoms from until it's way too late and until you've already developed heart disease. So regularly scheduled appointments, and then the team-based approach, because as you can see, diabetes can really affect the blood vessels in all of your organs for the most part. And so I can think of like 6 specialties off the top of my head that people with diabetes should be seeing on a regular basis.
My task in the next few minutes is to try to review all of the things you need to know about diabetes and peripheral arterial disease. So we'll speak briefly about the epidemiology. I think Nisha's lecture really covers most of the high points about the risk factors for atherosclerotic vascular disease. When I was in medical school, one of my professors called diabetes atherosclerosis mellitus as one of the nicknames for the disease, because it really keeps company with atherosclerosis. We'll talk about diagnostic evaluation, medical therapy, and some of the definitive treatment options as they're relevant to this patient population. So a couple of key references for those interested. There's a new guideline statement from about 18 months ago that covers all of this information in great detail from the societies that many of us are members of, and a couple of nice review articles that are accessible on the web and some appropriate use documents. But let's start with a case to kind of put this in clinical context for everybody. This is a patient I treated last week. She's a 72-year-old woman, type 2 diabetes, who presented to her primary care physician for evaluation of left leg pain while working. She still works full-time as a housekeeper. She's an industrious New Yorker. She can walk about 2 blocks before stopping because of left calf cramping. And despite this, she's continued to walk, but she finds that it now slows her down. And she's having a hard time performing her work in the same rapid way that she's used to. Her past medical history is notable for diabetes for about 10 years, hypertension, and high cholesterol. She's never smoked and has a family history notable for a father and a mother, both of whom died of heart attacks in their 60s. She's on aspirin, lisinopril, atorvastatin, and metformin, so it should sound familiar from what you just heard. And on physical examination, her primary doctor noticed that she had weak pulses in the left foot, which had not previously been noted. And I, frankly, was impressed that her primary doctor even took off her shoes and socks to examine her feet. So just keep this patient as a thumbnail in the back of your head as we talk about peripheral arterial disease. You've heard about atherosclerosis in detail from Nisha, but I think it's important to understand that peripheral artery disease is very common. And as patients age and as they develop risk factors, such as specifically diabetes, the incidence of peripheral artery disease increases. So if you look at this figure from top to bottom, as patients get older, the incidence of peripheral artery disease increases, such that most patients that we see in our practices, Medicare age patients, who are either age 70 or between 50 and 69 with diabetes or tobacco use history, about a third of those patients are going to have peripheral arterial disease. Now, unfortunately, only half of those patients will have overt symptoms and will know it. So this is a silent disease in many, many patients. And if you look at the overlap, those patients who have peripheral artery disease, about half of them will have significant coronary disease and vice versa. So these patients have a systemic disease, which we've already talked about, which is atherosclerosis. This is also about a quarter of these patients will have cerebrovascular disease or carotid stenosis and intracerebral disease, which can lead to stroke. So stroke, heart attack, and peripheral arterial disease run together. And many of these patients will have multiple manifestations of atherosclerosis. And if you ask patients, what are you more afraid of? Are you afraid of dying from Hodgkin's disease or breast cancer, or from the diagnosis of PAD? They'll always say that cancer is more frightening. But if you look at the mortality risk at 5 years, patients who are diagnosed with PAD have a higher mortality rate than those who are diagnosed with early stage breast cancer or Hodgkin's disease. And that's because of the systemic risk of cholesterol, plaque, called atherosclerosis, which is what's the underlying pathophysiology of heart attack and stroke. Now, if you look at men and women, and specifically focusing here on women, just like the incidence of heart disease, peripheral artery disease increases with age, and there are ethnic predilections that distinguish different groups and can, specifically here in New York in our population, results in an epidemic proportion, near 40% incidence of PAD in women over the age of 80 amongst African Americans and other groups, including Asian American Indians, for example. The risk factors we've talked about, diabetes, if you think about the magnitude of risk, smoking and diabetes confer the greatest amount of risk to the patients who develop PAD ultimately. And so again, diabetes is one of the principal risk factors. And as Nisha talked about, diabetic patients are predominantly afflicted by atherosclerotic vascular disease, and over 75% of all hospitalizations of diabetic patients with complications are resulting from atherosclerosis. And the patients with type 1 atherosclerosis have more diffuse disease, as you heard about, and have a dramatically higher risk of concordant nephropathy or kidney dysfunction. Off the screen on the bottom is that the fact that 2 to 5 fold excess risk of peripheral artery disease is seen in diabetics, and women are even higher risk for developing PAD. So this is another one of those charts from medical school that makes you nauseated, but I'd like to highlight the fact that, as Nisha pointed out, inflammation is thought to be a key driver of the development of progressive atherosclerosis. And so patients who have diabetes typically have a higher inflammatory environment in which they develop higher burdens of atherosclerotic vascular disease with more diffuse disease, have more plaque ulceration, which causes clotting or thrombosis, which ultimately leads to heart attacks and other kinds of limb problems, and a calcification, which becomes a difficult problem for us when we're trying to open or unclog these arteries. So patients at increased risk for PAD, again, I wanted to highlight that anybody over 50 or even younger than 50 with diabetes and any other risk factor is considered high risk. So we've realized over the last 3 decades that patients with diabetes are at amongst the highest risk for PAD, and these patients need to be screened aggressively. The clinical manifestations range from asymptomatic in 50% of patients to the type of symptoms that my patient was describing, intermittent claudication, which is the clinical description we give to calf cramping with walking. And then older patients can develop functional impairment with difficulty walking, and they can develop ulcers or even gangrene, which is not uncommon in diabetic patients who have severe neuropathy and can't feel their feet, and then develop ulcers that get infected and can't heal properly because of lack of circulation. We have a couple of different grading scales, and I think the most important one is this one called the Rutherford scale, where we can measure how bad people's intermittent claudication or PAD is based on how far they walk. And I used to practice in Cleveland, where walking a block didn't matter as much as it does here in New York City. But if a patient can walk with limited symptoms and go as far as they want, they have a Rutherford 1. If they can walk more than 2 blocks, that's a Rutherford 2. Less than 2 blocks, that's a Rutherford 3. And this is sort of mild, moderate, and severe symptomatology. Once you get past that and have pain at rest, you have a different kind of a problem, which we call critical limb ischemia, which I won't talk too much about. The examination, if patients have suspected PAD, should include a full pulse exam, as well as measurement of both arm blood pressures and looking for findings that are consistent with poor circulation. I know that we were at the dinner hour, but I'm going to show you a couple of pictures of what we might see. Even in a dark complected patient, when you raise the legs and the feet get pale white, that's a sign that the gravity is helping the blood flow. And when people have gravity-dependent circulation, they have PAD. When people develop these kinds of ulcers, and believe it or not, this patient didn't notice that they had these kinds of wounds on their feet, and because they have diabetic neuropathy. So this is the kind of thing we see. So how do we evaluate these patients? We do things that are very similar to what the cardiologist does, and I get to wear both hats most days. And so, for example, we do something called the ankle brachial index, and then other tests. But really, the ABI is the EKG of the legs, the most simple and effective screening tool. And we do that by measuring blood pressures in both arms and both feet using a Doppler ultrasound. And then we take a ratio of the higher of the 2 ankle pressures over the higher of the 2 arm pressures. And we decide whether that is normal or not. Simply put, the pressures in the legs are usually equal or higher to those in the arms. And if the pressures in the legs are lower than in the arms, that's abnormal and usually a sign of peripheral artery disease. And so ratios less than 0.99 are considered borderline, less than 0.9 are considered abnormal and diagnostic of PAD. Patients with ratios less than 0.4 are at risk for spontaneous gangrene. So this is our patient, the woman that I described to you. And you can see these, you don't have to be a cardiologist to recognize that these pulsatile waveforms look different than these flat lines. A flat line in medicine is generally a bad thing. And so here you can see on her left leg, which was the symptomatic leg, the pulses measured down at the ankle are diminished and there's less pulsatility of this. And when she exercises by walking, those pulses get even worse. And that's reflected in the pressure measurements down here. So she clearly has documented peripheral arterial disease in every way. So the diagnostic workup is a history and physical, an ankle brachial index, and then if we need to get more information, we do additional testing. So we've made the diagnosis, and the good news is that if patients are treated properly, the average patient will stay pretty stable over the ensuing 5 years. Only about 10% of patients will go on to needing surgery or amputation. The problem is about a third of those patients will develop some sort of morbid or mortal cardiovascular event, and 75% will go on to dying from a cardiovascular cause. So any patient with peripheral artery disease, in my opinion, probably deserves a visit to the cardiologist just to make sure that they're on the appropriate risk factor modification to prevent any of these downstream complications. And these are the guideline-dependent risk factor modification treatments, and Nisha went through all these. It is not a coincidence that they are almost identical to the guidelines for the treatment and prevention of coronary artery disease. And both the American Diabetes Association and the American Heart Association have adapted the guidelines to really be coincident. And it turns out that if you are in the group in blue and you're taking guideline-directed medical therapy, your risk of having a major cardiac event or limb event is much lower than if you're not taking guideline-directed medical therapy. So following the guidelines, getting treated for all of the risk factors will save lives and limbs. Then eventually, when we need to treat patients, if their symptoms are so bad, we have to restore the blood flow. And those patients who have claudication, like the patient I described, they can get their treatment whenever. And we are judged by how long that the treatment will stay open, or something we call patency. This is like angina in the coronary literature, where patients who have chest pains with exertion that goes away with rest, or what we call stable angina or angina, depending upon which continent you're from. Those patients can be treated medically for a long time before they need treatment. But those patients who develop heart attacks, or in our case is critical limb ischemia, they need to be treated right away, because if we don't, they're going to lose their limbs. So the patient with critical limb ischemia, I just want to make the point that once a patient is diagnosed with critical limb ischemia, 1 in 5 of them will be dead in 6 months from a cardiovascular cause. So that's a very, very serious diagnosis. And these are some of the most at-risk patients that I take care of. About a third of them will be alive with an amputation, and hopefully a minor amputation instead of a major amputation. And almost half will be alive without an amputation, and even more nowadays that we have better medical therapies. So my job is to improve their inline flow to their feet and treat not just the big vessels, but the small vessels. And we try to avoid surgery whenever possible because of the risk of perioperative complications in these patients who also have heart disease. We also make sure that these patients have excellent foot care, and I can't, with a diabetes specialist in the room, I can't emphasize enough that these patients need expert foot care, because many of the patients can't feel their feet, and they need somebody to take care of their feet in addition to their primary care physicians, who frankly just don't have the time or often the interest in taking off the shoes and socks. So I'm going to show you the angiogram of this patient who, after a medical therapy and risk factor modification, really begged us to do something because she wasn't able to work, and she still needs to work to maintain her livelihood. So for those that are uninitiated, this is the aorta, this is the right leg, the left leg. The arteries up until the hip joint look pretty good, but then as we inject dye from the hip down, you can see this is the artery called the superficial femoral. It's sort of the superhighway from the hip to the knee, and you can see some lumps and bumps. And then as we get further down, you'll see that there's a total blockage blood flow stops here and then restarts here, and it's getting around this blockage through the body's own bypass channels that we call collateral circulation, which develops when patients are walking and have this kind of arterial disease. So a little better picture of this is shown here. You can see there's a total blockage from here to here. That's about 5 inches in her thigh. And then the artery resumes with some lumpy, bumpy disease, but fortunately not too bad of blockages down. And then you can see we have pictures all the way down to the foot where we can see that their blood actually reaches the foot pretty intact. So we have a lot of great treatments, but whereas this patient used to get bypass surgery, we now can, with specially developed medicated balloons, do balloon angioplasty and restore flow in about a procedure that lasts about 30 minutes, and that the patient can walk out of the building in about 4 hours. And so, she said immediately that she felt better walking, and this was done on Monday, so I'll be seeing her in follow-up on the following Tuesday. So we'll see how she's doing. But she told me she was going to try not to work this week, but I don't have any bets on that. She's a hard charger, and I bet you she's back at work already, despite doctor's orders. The last thing I wanted to leave you with is that certain geographies in this country have low rates of revascularization. So the treatment I just showed you was really pioneered by scientists at the Cardiovascular Research Foundation and at academic institutions all over the country, and it's really easy and effective. The problem is it's not widely available. If you look at these areas that are lighter in color, they have very few revascularization procedures done, and you can see that there's geographic differences. Here in New York, we don't have any problems. We're pretty well covered. But the inverse of that is amputation. So where there's less revascularization, there's more amputation. And amputation is an epidemic problem here in the United States, and the diabetic patient is the most at risk. So for those that have end organ problems such as heart, cerebrovascular, and peripheral artery disease with diabetes, they're at high risk for amputation. And depending upon where they live, they may or may not be able to get access to the kind of care that we just showed you for our patient. So let me summarize that PAD is a common manifestation of systemic atherosclerosis. Diabetic patients are at high risk for development of PAD and the subsequent complications, 3 to 5 times the standard risk, and that early diagnosis and medical therapy can delay or prevent clinically significant disease. Thanks very much.
Once again, thank you guys so much for being here. I always like to encourage and applaud patients for taking that extra step to come in and learn a little bit more about how to improve your health. So good job, guys. Way to do that. I want to start with just giving you some tips. And how many people looking at this are already overwhelmed by diet, nutrition, right? It involves a lot of lists, right? Of checkoff lists of things you have to do, right? But my hope for tonight is that I can simplify that for you. And we're going to do that by really focusing on these 2 main areas, because really everything else in blue is kind of summarized. You heard Dr. Golden talk about balanced diet. So I really want to focus on that. What does that mean exactly to have a balanced diet, right? So we're really going to focus on that. And then adding more movement. You've already heard a little bit about that, so I probably won't spend too much time on it, but I cannot stress to you the importance of that. Our bodies are made to move, and when we don't do that, bad things happen, all right? So we're really going to focus on these 2 things, but like I said, we'll hit these other points as well. So how many of you have seen this before, right? This isn't new. It's been around for a while, and it's the MyPlate method, right? And what you notice here is half a plate, or a majority of what is on the plate, is non-starchy vegetables, right? But the carbohydrate is still there, all right? And if we're going to talk about balance, and as complicated as it can get, this is how we keep it simple, right? We look at a plate, we look at your food, and if you're able to understand and basically identify the foods that we really want to minimize compared to the foods that we really want to maximize, then you're able to achieve that balance. But if you have no idea what these foods are and kind of what foods fit in which category, then it's going to be really difficult to achieve that balance, okay? So that's why we're going to kind of start by breaking this down a little bit further. But keep this in mind. And as you keep this in mind, I also want you to kind of start picturing, or maybe, imagine or think about maybe some of your past meals, maybe some of the food that has been typically on your plate compared to this, all right? And it's not a judgment, it's just where are you at now? Because you have to really look at where you're at now to better identify and kind of point out what might need to change. So there's 3 main nutrients in food: carbohydrate, protein, and fat. And that's what we're going to spend most time on. Carbohydrates. You heard Dr. Golden talk about blood glucose, right? And when it comes to blood glucose, a good portion of that, other than what comes from our liver, comes from carbohydrates. You heard her talk about insulin resistance, right? And I'm going to get back to that, but when it comes to diabetes in particular, as well as just overall weight gain, a lot of our calories come from carbohydrates. And it's not that we cannot have them. This list is not a list of foods you cannot have, but it's a list of foods you have to be aware of. It's a list of foods that you have to be able to look at and again, decide for yourselves, am I eating too much of this compared to the other categories of foods we're going to talk about? The foods in red are those complex carbohydrates Dr. Golden mentioned. Those carbohydrates that are more full of fiber and other nutrients, other vitamins, that are actually giving your body more of what it needs, as opposed to just requiring your body to produce more insulin. Okay, so we're going to bring this all together. But again, looking at this list of foods and picturing that plate, are you potentially eating too much of this category of food? Is there room to potentially, again, bring down those portion sizes of this area of foods? Protein. And protein and fat are somewhat combined. But when it comes to protein, we really want to choose lean proteins. Proteins such as skinless chicken, turkey, lean pork, lean beef, fish, 2 to 3 times a week if possible, salmon, lake trout. It's the reason is because those are, those contain more of our healthy fats. Has anybody ever heard of the Mediterranean diet, right? So again, it's focusing on those healthier fats. And that's why we want to definitely include some fish if possible. We want to limit our red meats, the fattier cuts of beef and lamb and pork, and then avoid those processed meats. And this is the hard part. You're going to hear me talk about processed foods a lot because unfortunately it's become more of a staple in our current American diet than it really should be. So we really want to avoid those deli meats, ham, bacon, pastrami, salami, hot dogs, pepperoni, and there's a couple reasons for that. One of the reasons is, yes, they are packed full of fat, but they also contain very high amounts of sodium as part of their processing. They do have a lot of sodium, which we're going to talk about in a second. So talking about proteins is a good segue into our fats. And I've really, again, simplified this to our saturated fat and unsaturated fat. You've heard a couple of the doctors mention tonight LDL cholesterol, right? And especially for people who have diabetes, really wanting to reduce our LDL cholesterol. And yes, there is medication that can help us do that. But you can also do that by choosing those healthier fats, right? If you look over on the right-hand side, the list of foods that have more of our unsaturated fats as opposed to the saturated fat. I also like to simplify this by thinking, okay, it's not like you're going around thinking, okay, is this saturated or unsaturated? But one easy way to really differentiate the two is our saturated fats most often come from animal products. It doesn't mean that you have to become a vegetarian. But again, if you think to yourself, oh, I ate an animal, product for breakfast and for my snack and at lunch and at dinner, chances are you're overdoing the saturated fat, right? Another way of thinking about saturated fat is they're solid most often at room temperature. Think about butter, right? If you leave it on a table all day long, it's not just going to melt, right? You have to apply heat to that. So a lot of our saturated fats are solid at room temperature, whereas our unsaturated fats, olive oil, peanut oil, right? Those vegetable oils are liquid at room temperature. So that's another easy way to help differentiate the two. Sodium. Sodium it's a tough one because, again, in all of those processed foods that we have come to know and love, that is where the highest percentage of our sodium intake comes from. It's not actually from the salt shaker. Yes, we do need to be aware of it, but it doesn't all come from there. I was amazed to find that even though the recommendation for sodium intake is, less than 2,400 milligrams, even for a lot of us, especially people who have certain risk factors, less than 1,500 milligrams, the average American eats more like 3,400. So you have to be intentional about this, okay? We have to be intentional to help reduce our sodium intake. The salty six, and I'm just going to put these up here quickly. Oh, we can go back. Bread, a lot of people don't realize, but something like bread, we all eat a lot of. Like, you don't even probably think about the number of times we eat bread. And there's not huge amounts of sodium in one slice, but if you're having multiple slices a day because sandwiches are your go-to, then it's something you have to be aware of. Those deli meats come up again, right? Not just for their fat content, but again, this is where the sodium comes in. A pizza, and trust me, I am a New Yorker. I love pizza just like the rest of us, but a pizza kind of has everything combined, all those high sodium foods combined, much like a sandwich, right? And then you're probably thinking, why is chicken up there? Well, chicken is a very common protein for a lot of people, and because of that, and because it can, it's on the cheaper side when it comes to animal proteins, we like to doctor it up. And we doctor it up with all those different seasonings and sauces, and it's those things that tend to be higher in sodium. So you have to really watch that. So I go back to this picture, right? And even though I know I covered a lot of information in a very short amount of time, I'm used to having an hour to present this information. This plate really, again, it encapsulates all of that. If you're eating majority of your food being non-starchy vegetables, it can't be super high in fat, right? It can't be super high in sodium. It's not going to be too high in carbohydrate, right? Notice even in the carbohydrate portion, yes, white rice is there. Because I really want to point out, and it's something that has been mentioned before, this is all about a sustainable lifestyle, okay? And I want you guys to be able to make these changes and continue these changes. And that means we have to start with where you're at. And if currently, if you're honest with yourself, the majority of your plate is white rice, to ask you to just completely move white rice and move in the quinoa is a little unrealistic, right? But if I just ask you to, let's start with just cutting down the portion of white rice and increasing those vegetables that you like, that's a bit more doable, right? And we can focus on making those healthier carbohydrate choices later, but really start with looking at the portions of the foods that you're eating, focusing on those lean proteins and getting as much vegetable as possible. I just want to mention something that has already been mentioned, but 2.5 hours is the current recommendation, all right? And here's kind of the maybe the stab to the heart moment, but does this sound like a lot or a little to most people? Little. Good. I'm glad. Because the next question kind of brings it home. If it sounds like maybe a lot, or if you've told yourself, or you're kind of in that cycle of maybe not exercising very much, or, oh, I don't quite have time, how much television do you watch a day? Right? Okay, and maybe TV's not your thing, but how much time do you spend on social media? Or on your computer? Or chatting it up with friends? It's not that any of these things are bad, but these things often take priority over something that is vital for our health, right? And has so many benefits. So it's one of those moments and times to really just be honest with yourself and really work to make this a priority in your life. I'm a huge fan of goal setting, but we have to set realistic goals. I'm also, and my husband is the first to say this, I'm a planner. And a lot of us are, but especially when it comes to exercise, especially when it comes to these lifestyle and dietary changes, you have to have a plan. Because if you're just trying to wing it, chances are it's not going to work, especially because we're talking about habit change. So make a plan for yourself. Write it down. Tell somebody about it. That accountability is really important. It's almost like when you say it out loud, it makes it real, right? Say it out loud. Say it to somebody else to make it more real, and you're then more apt to actually follow through with the action, which is what is the most important part. I'm not going to talk a whole lot about weight loss just for sake of time, but all of these things are what leads to the weight loss, right? And you've already heard Dr. Golden talk about that insulin resistance. But as we're able to kind of give our body a little bit of, almost like a little bit of a break, right? Give those beta cells, those insulin producing cells, a little bit of a break by reducing our caloric intake and then exercising, which helps with that resistance, and then leading to weight loss. Again, we're talking about benefits, not just in diabetes management or prevention, but for hypertension, reducing your cholesterol, right? So it carries over into every area of your health. And we're not talking about huge numbers. 5 to 7% is incredibly effective at both prevention and management. So just to wrap up, again, really the focus is overall achieving and maintaining that healthy weight, but we do that by eating a well-balanced diet, moving more. Don't get caught up in that checklist. Really, and again, I'm a visual person, so that keep that plate in the back of your mind, and you're really going to be hitting all of those points.